40 again. Okay, so you get some sort of damage on the inside of the artery. This is probably as good a time as any to talk about. I apologize, Zoomers, but I can try to roll this up a little bit more, but you guys probably can't see it anyway. We have an artery, okay? Artery. I had a teacher in high school that would draw a line. It was in a zoology class. He'd draw a line on the board, and he would say, Serengeti Plain, Africa, right? You know, 1,000,000 years ago. And we'd talk about like lions and giraffes and why the giraffe's neck is tall and those kind of things. But, anyway, artery, okay? We have this space in the middle of the artery is called the lumen. So the distance, basically the diameter or the width of the artery is called the lumen. When you get atherosclerosis, the space, the luminal space shrinks and becomes small. You also have in every artery and arteriole, you have a layer of cells on the inside of the artery. And this layer of cells is going to be the layer of the artery that makes contact with the blood. This layer of cells is called endothelium. The endothelium is unbelievably important, okay? Unbelievably important. And so when you get damage to an artery, a lot of what happens is you get a little nick or something, a little bit of a little tear in the endothelium, right? Like having a cut anywhere in your body, you get a nick in the artery, and it evokes an immune response, okay? It evokes an immune response. The immune system wants to come in and try to fix it and try to repair it, okay? First problem, right? So what happens then is there is this initial lesion, okay? You are then going to very often get infiltration of macrophages, which are a special kind of white blood cell. Okay? In order to begin to develop atherosclerotic plaques, you're going to need lipid to get stuck. So particularly LDL cholesterol likes to get stuck in those lesions. And then the macrophage comes in and it wants to try to eat the LDL that is in that lesion. So what happens then is the macrophage eats the lesion and it tends to form something called a foam cell, okay? The macrophage can't like totally digest all the LDL. It's like, we don't like this, and it just kind of explodes and becomes what's called a foam cell, which is just like this kind of yucky, fatty looking little cell, okay? Now you have that stuck in there. So I had a lesion, I got some LDL in it, I had a macrophage come to try to help us and get it out. The macrophage couldn't do it, and so its solution is, okay, we've made this foam cell that is stuck in the endothelium, and now that begins our fatty plaque, okay? As we're going to move then, we're going to continue then, we've got our little lesion here. Then if we get another lesion in and around that same area, because now I got a foam cell wagging itself out into the lumen of my thing, that may increase the chance of getting more damage right there. As that continues to build over time, we're going to continue to accumulate lipid and macrophages into those spaces. We make more and more foam cells, and the foam cells begin to get pushed down into and around the endothelium, and they begin to stack up on each other, okay? They begin to stack up on each other. That leads us into this kind of intermediate lesion that is going to be here. We're getting lipid accumulating in kind of these, in this cell layer, okay? Eventually, this is going to, you're going to get enough of these things that we're going to form what is called an atheroma, okay? We're going to form these atheromas. And so to get an atheroma, there's lots of lipid that has been deposited in here, lots of foam cells, but then Because of all of this, this evokes a further immune response where macrophages and platelets are going to activate the smooth muscle out here around the artery, and it's going to create this environment that's going to lead to the deposition of collagen and some things that are going to make this very fibrous. Okay, and so now we've got our lipid core. We're beginning to get more kind of fibrous pieces that are going to be deposited in there, and you begin to put this fibrous cap on the outside. And so eventually, as we get to this place, what happens is the immune system basically gives up and says, we can't get this out. Let's cap it off with this fiber as a fibroatheroma, and then you're just kind of stuck. Okay. Now it can't go away. We're just going to seal it off and hope for the best. Okay. Then, as that continues to go on, you can get a surface rupture in that kind of fibrous layer, and you can split off some of these fatty plaque, this inner kind of lipid layer, which can get stuck and cause ischemia here, or it can get stuck not so much here, but someplace else, and it can lead to blood clots and stuff like that. Okay, so if you guys really, really, really want to know all of the intricate details of this, I can give you some excerpts from a medical physiology textbook, and it will tell you all of the gory details, right, of all of this. But what you can note here is it's going to talk about the onset. From your first decade, so before you're like 10, you may begin having some of these things. Most people aren't going to get these intermediate lesions or these atheromas maybe into their third decade of life, so by the end of your 20s, okay? And then once you're into your sort of fourth decade, basically, you're into your 30s and your 40s, you may begin to see these kinds of things, okay? So this is going to be this area, once we're kind of getting down here from the atheroma stage on, where there's going to be things that may have a clinical presentation as high blood pressure. It may have a clinical presentation as a reduced blood flow to certain tissues, okay? And that is going to be accompanied by increased risk of blood clots. And so this is going to be kind of the big issue, okay? All right. So this is atherosclerosis. This is the thing that kills most people, okay? Is that eventually the atherosclerosis becomes so bad that it shuts off blood flow to the heart or to the brain or the peripheral tissue, and that tissue dies, which is bad, or you'll get a break from one of these plaques and you'll get a blood clot that will then get stuck in another area, right, because it's so narrow, or that blood clot will then travel into your lungs and it'll be a pulmonary embolism or something. And so that's where the bad, kind of the really bad things are going to begin to happen. Okay. Okay. So you have all of this atherosclerosis. Let's imagine that the place where it tends to occur, atherosclerosis tends to develop at places where there are going to be damage to arteries. So the places where the arteries are they're most likely to get damaged are in arteries that have high pressure and arteries that split or bifurcate a bunch, okay? So this tends to happen more often because of higher pressures in arteries closer to the heart and in arteries that are more highly branched, like the coronary arteries or like your cerebral arteries, okay? There's something about, do I have anybody, probably in some ways, Bria's not here, but do I have anybody that's like a canoeer or a kayaker or a whitewater raft person or anything? You guys know about, like, ever been on one of these things? There's like rocks in the water and it splits and the water goes around and it creates these little kind of whirlpools and eddies and things. Well, your blood is a fluid, and when it reaches a place where it splits, it creates this turbulence in your blood flow. And when it is more turbulent, then little particles in there can actually nick and cause damage more often on the endothelium. And so my take-home point from all of this is that because of their high pressure and their high level of branching, the coronary arteries are at a particularly high risk for the development of atherosclerosis. Right? So when you get that in the coronary arteries like we see here, you're going to develop coronary artery disease. Okay? And so what happens with coronary artery disease is a combination of two things. Okay? By sort of making the luminal space small, the pressure is going to go up. Okay? And by making this thing small, less blood flow is going to be able to get through. Okay? When there is inadequate amounts of blood flow going through the coronary arteries, then the cardiac muscle that is downstream of that area is going to become what we call ischemic. Ischemia denotes a lack of a proper amount of oxygen. Okay? Hold your breath, you can become ischemic. And then you breathe again and you're fine. Okay? I can have you guys, if you really want to do it, you can like reach right up here in your armpit and you can squeeze down on your brachial artery and you can begin to get some tingling feelings down the rest of your arm. You're becoming ischemic downstream. So in the heart, when you're ischemic for a prolonged period of time, then that cardiac muscle will begin to die. Okay? It will begin to die because it's not getting enough oxygen to keep it alive. Okay? This is called ischemic damage. When you get ischemic damage, two things happen. First, the ventricles become weaker. They're unable to contract as forcefully as they could previously, which means stroke volume falls, which means cardiac output falls. Also, because they are weaker, as blood pressure increases because of these narrowings all throughout the body, as blood pressure goes up, then you may reach a point where the ventricle is not strong enough to generate enough pressure inside of it to overcome aortic pressure. Okay? So both of these things are very bad. Right? The other thing that happens, right, is there is damage. As cardiac tissue dies and becomes damaged, it impairs the function of the cardiac conduction system. And so you get damage in the heart, and that may lead to an inability to transmit action potentials across the surface of the heart or through the Purkinje fibers that are in that area, okay? And that can lead to arrhythmias so that the heart doesn't contract correctly, and that can lead to AFib or VFib or some other things that are very, very bad. They can basically lead to cardiac arrest, okay? So it dies and it becomes weak, which is not great, has some implications, but it also can have these impairments in cardiac conduction. Most people, when they have a heart attack, okay, what they are feeling and experiencing is an acute loss of oxygen into this tissue, okay? You can literally feel the cardiac muscle beginning to die, okay, when you're having a heart attack. And so it's possible that is due to the fact that you've had some extra deposition, or there's been some kind of a blood clot in here, and you've had a little bit of tissue damage for a while but never knew it, and then all of a sudden it gets plugged up and boom, a large piece begins to do all of this, okay? And so you may have a heart attack by it gets ischemic. As it becomes ischemic, it switches over to anaerobic metabolism, it makes lactic acid, and that is what's causing the angina pain that people feel. It's an accumulation or an acidity that is beginning to accumulate from lactic acid in the heart. The heart does not have its own pain fibers, its own pain afferent nerve fibers, so it borrows the surrounding tissue. And so I'm ischemic, my shoulder hurts, my left bicep hurts. Especially in women, it tends to radiate up into y'all's neck, more so than in men, okay? The chest feels kind of full and swelly, those kinds of things are kind of what the typical heart attack symptoms are. Oftentimes, this gets exacerbated, okay? It gets exacerbated during exertion. You're fine right now. Tessa's fine. But yet she's got a very narrow coronary artery. We ask her to exercise, her blood pressure goes up, it tries to raise her cardiac output. And so then the heart needs more blood flow, and she's not getting enough now. And so then it begins to come on and she gets that pain. Then she stops and she sits down and voila, it goes back to normal, okay? Mild coronary artery disease or sort of a mild kind of myocardial infarct from this ischemia usually doesn't cause unconsciousness. Usually you just kind of feel this, it comes on with exertion, and then it goes away. Okay? If this gets really bad, though, and it messes up cardiac conduction, you can go into cardiac arrest, and that could be what kills you. Okay? Are we all okay with this? Yep. Okay. So, fun pictures. I assume in anatomy class you guys got to see a whole bunch of different coronary arteries and had to learn them and label them. This is a picture here in the bottom left. They've dissolved away all of the cardiac muscle, and all you're left with are the blood vessels. And so you can see the heart is one of the most highly vascular tissues in all of the body. And so you can imagine that if I get atherosclerosis and I get a blockage high up in some of my large kind of primary coronary arteries, there's a lot of tissue downstream of that that's going to not get enough oxygen. Okay? So here's a picture of what's called a coronary angiograph. It's really just a high-res X-ray where they've injected dye into a person. This is a normal one. This is the heart here, kind of darker shades. And then these are going to be the coronary arteries going around it. Here is, so this, what you can see here and here, this is the left anterior descending coronary artery, which apparently is a thing, right? I've never had an anatomy class. I don't know what the hell that is, but it is a coronary artery. And so what happens is, as the blood that has the dye in it moves through, it's going to show you how big the arteries are. And so you can note right here, in this particular artery, it's not gotten pinched down. All that it's telling us is what you see in dark is the size of the luminal space. And so on our picture here, you can note that in this one, this is about a 95% narrowing of that artery. So basically everything downstream of this is not getting adequate blood flow, or is at a very high chance of that. And because it's so narrow, it doesn't take a very big blood clot to be able to shut that whole thing off. Okay? So this person would need to have coronary bypass surgery or some kind of revascularization. Okay. What's going on here? Let me check the time, guys. You may need to be. Let's go ahead and take our break real quick. Okay. We'll come back at 12:12, and then we'll keep rocking and rolling with this. So now that we know a little bit about what coronary artery disease is, okay, let's talk about who gets it, how can we guess if you're going to get it, right, so that we can know for whom we need to try to design some interventions. So if we look at risk factors for coronary artery disease, look at these. Primary, smoking, hypertension, blood lipids, so high LDL cholesterol, low HDL, high triglycerides, physical inactivity, and obesity. Secondary are having diabetes, having a family history of coronary artery disease, being a dude, okay, and advanced age. Do these things look familiar to you all? Kelly's nodding her head yes. They should look familiar to all of you. Why? We just went over them as what, Zach? Risk factors for what happening during a bout of exercise, right? So these are the risk factors for coronary artery disease. The reason that these are the things we screen for to see if it's safe to have someone exercise is because what we're worried about is you have coronary artery disease and we have you start to exercise and you have a heart attack. That's what we're worried about. You go into cardiac arrest, okay? So basically it should be pretty easy to remember the risk factors for coronary artery disease because these are the things that we use when we do a health appraisal, okay? So they're pretty much the same kinds of things. All right, so let's look at and try to stratify people out. who has a heart attack or who has, right, increased coronary artery disease risk. And so what we're going to look at with all of this is that about 10% of the population, right, there's about a 10% risk increase with high blood pressure, 10% with cholesterol, about 20% with smoking, okay, and then about 60% of the population has this, this increased risk from physical inactivity. So this is the big deal, right? Look at this. If I can just be active, I can knock out this giant portion of the population that is somewhat at risk or somewhat at increased risk because of all of these kinds of things. And so this is, we're kind of back to our same graph that we've had the whole time, that if coronary artery disease is one of the primary causes of death from cardiovascular disease, and cardiovascular disease is the primary cause of death of most people, if we can reduce the risk of this, we can reduce the risk of cardiovascular disease, we'll reduce the risk of all-cause mortality, which is kind of why physical activity is so important in the midst of this. And as you guys will see, if I'm physically active, I'm less likely to smoke. If I'm physically active, it will lower my serum cholesterol. If I'm physically active, it will likely lower my blood pressure if I'm hypertensive. So this is the thing. This is the one. If we can target this, we can have these very nice knock-on effects on some of our other risk factors. Okay. All right, so here are the ACSM risk factors that we use in our screening questionnaire. Okay, here are the ones of those risk factors that can be positively impacted, okay, by being physically active. If I'm active, I'm no longer sedentary. If I'm active, it's going to help reduce my fasting blood glucose levels. It's going to lower my cholesterol levels. It's going to lower my blood pressure. And it may, although not always, but it may help me to lose a little bit of weight if I am obese and potentially lower my BMI. So 5 of 7, basically, everything but smoking and family history can be directly impacted in a positive way by being more active. There's lots of evidence that if you're more active, you're less likely to smoke. So that's good, okay? And then family history, we can't do much about. That one, we're just kind of, we're stuck with your genetics are what your genetics are. Okay? This right here, okay, the collection of all of this, you've got to be kidding me. The collection of all of this is why I've been yelling at you guys the entire semester about exercise is good, exercise is good, physical activity is good, physical activity is good, okay? It's all because of this. When you are more active, it improves all of these risk factors. And when you can improve all of those risk factors, you're less likely to have atherosclerosis, less likely to have coronary artery disease, less likely to die from cardiovascular disease, so your all-cause mortality goes down. Okay? So, fun things to look at. I don't know why Dr. Pinku picked out our pictures of our chimpanzees here, but we here have our poker playing sedentary one. Here we have our hockey playing exercising one. But if we look at the blood vessels of you guys, or of people that are my age, people that are sedentary, theirs are going to look like this. Their vessels are smaller to begin with, and they have some plaques in them. So they're narrow, more narrow on the inside. Exercisers have less plaque or very little plaque. You're kind of a chronic exerciser, and their artery is bigger to begin with. So even if you had some plaque, you've still got a bigger luminal space than a sedentary person. Okay? This is the big thing. Exercise lowers LDL cholesterol, so there's less cholesterol to get stuck in there. It lowers blood pressure, so there's less driving pressure to cause those kinds of nicks. It causes this vascular remodeling, which is going to be good as well. Okay, so we know that exercise reduces coronary and cardiovascular disease risk, right? So we've talked about all of these other things. Okay. The other piece at the very, very bottom, and I'll talk about this, and then because of the Zoom issues, we'll just call it a day, and we can all go have a beverage of our choice at the end of all of this. So it improves our inflammatory profile. we haven't talked about this because it's probably beyond the scope of class, but have you guys heard of something called a reactive oxygen species? Anybody heard of that? A reactive oxygen species, or an ROS. So oxygen is kind of a, how to put this in a term you guys will understand. You guys know what a whirling dervish is? No? Never heard of a whirling dervish? You guys watch cartoons when you were little? You see the Tasmanian devil, right? No, you guys know what the Tasmanian thing was on Looney Tunes, right? He goes so fast, it's like a dirt cloud, and his arms are, his arms are out there all over the place. So oxygen really wants to grab charges from surrounding molecules, okay? It's very unstable. It wants to grab charges. So it reacts with things, and not in a good way, okay? Not in a good way. It's a troll, right? If we want to use one of our online kind of things. And so it causes all kinds of problems. So when you eat more fat, when you are more sedentary and things, you make more of these what we call reactive oxygen species. When you exercise, you can reduce these reactive oxygen species. These reactive oxygen species are going to cause more immune system ramp up. They're going to cause more inflammation. They're also going to, weirdly enough, they correlate with damage to arteries. We're not 100% sure how, but they correlate there. So exercising to lower that risk, okay, is good. Zach asked earlier about other things that we can take. Yes. You guys heard of things called antioxidants. Antioxidants are things that neutralize reactive oxygen species. Okay? So go drink pomegranate juice. It's an antioxidant. Vitamin C is an antioxidant. Okay? So there's a host of stuff that are like that, and they have some artificial things that do that as well. So you can take supplements. You can go to GNC right now. You can buy a little supplement package. It's got like 5 pills in it, and it's meant to reduce systematic inflammation, and all it's full of are things that are antioxidants. Okay? They work. Okay? They work. So that's a potential place where both exercise and supplementation we can intervene in the midst of all of this. Okay? Lots of kind of big stuff coming in that particular area. So there we go. Okay, let's stop here because Zoom is going to go kaput on us, and we'll try to pick this back up on Monday.